My name is Soroush Zaghi. I went to Harvard Medical School. I graduated ENT residency at UCLA, and that's where I got interested in sleep and breathing, and I went on to Stanford to do a fellowship in sleep apnea surgery. I always start my lectures by acknowledging the mentors who trained me. I went to Stanford to learn about advanced surgical approaches, but I'm really fortunate because they also took a step back and introduced me to other aspects so we can be truly multidisciplinary, including sleep medicine, sleep dentistry, as well as the myofunctional sciences. Now I work as medical director of the Breathe Institute, and I'm thrilled to have my team here with me, where we're really dedicated to patient care, research, and education. It's the first ENT clinic in the United States that has myofunctional therapists embedded inside the clinic. Myofunctional therapy is the first-line treatment, and we're really thrilled to be working with over 50 therapists throughout the country to bring these issues to attention. But my journey didn't start with myofunctional therapy or tongue ties. It actually started with an interest in MMA surgery. I went into fellowship wanting to learn to cut and to physically open the airways. And so my first research started off in maxillary mandibular advancement surgery. And so, I did this meta-analysis showing, 518 patients, 45 studies, that MMA is a terrific option to open the airway. 65 to 80% improvements. How do you get better than that? But if you take a close look, yes, the surgery is successful, but very few patients are cured. A lot of patients are left in that gray zone that we talked about earlier today with the UARS and the mild sleep apnea. And so while doing research is one thing, I went to Stanford and actually did these cases, did about 50 cases. And it was just one too many that I would consent them and put them through these ginormous surgeries only to find that they still weren't completely cured. And what oftentimes we found is that the tongue back here is still blocking the airway. And that's really the foundation of how Frenum restrictions applies to airway health. And then we got interested in maxillary expansion. Yes, you can expand the palate in adults, and it's very effective, 77% reduction in the apnea-hypopnea index. But very few patients, actually no patients are cured. And even when you look at pediatrics, 70% reduction, very incredible. But what's going on? What else is there? Because if you look at these kids and these adults with these high arch palates, you may notice the narrow nasal cavity that contributes to the upper airway resistance, making it more difficult to breathe through their nose. You may notice the septal deviation that results from buckling of the septal cartilage. But what often goes underappreciated is the position of the tongue. So you have a low tongue position in a lot of these cases. And what's more, it's the function of the tongue. So a lot of times what we see is a low tone tongue.
Lift up your tongue. And open your mouth wide.
Much better. Yeah, that's
Stick out your tongue.
Very well. Yeah, thank you for your solo. You see, I didn't think about well deserved.
Point your tongue.
So this is a patient who actually had a frenectomy with me. And so now she no longer has restricted tongue mobility, but the tongue is so low in tone. She can barely hold up her tongue while she's awake. Can you only imagine what happens when she falls asleep? When you're breathing, you should breathe through your nose and down your throat. But what we have in these sleep-related breathing disorders is oftentimes a low-tone tongue. And so you open your mouth, either due to nasal obstruction or tongue tie issues or whatever else, and the tongue falls back to block up the airway. And so really, the tongue should be up against the roof of the mouth. And when the tongue is up against the roof of the mouth, you're able to breathe comfortably through your nose and down your throat. But if you have a tongue tie that holds down the front of the tongue, or a posterior tongue tie that holds down the back of the tongue, what you have is an inability to seal off the nose from the mouth, and you're going to be a predominant mouth breather, and you're going to have a low tongue posture, blocking the airway, contributing to snoring and sleep apnea. And so the solution is to get the tongue up in the roof of the mouth. And this is what we want for our procedures, because when the tongue is up in the roof of the mouth, it's nicely suctioned, there's a nice seal, and it keeps it out of the airway. And so here's a 5-day-old infant with naturally optimal tongue position. When the tongue is up, even in infants, the tongue is out of the airway. When the tongue is down, it's directly blocking the airway. So what we want is to get the tongue up. But sometimes you have a tongue tie. And the tongue tie is physically going to tether the tongue to the floor of the mouth. It's physically holding it down. so that you can't get your tongue up. And so what happens is the tongue assumes a low position. It loses more tone as the patient ages, until the point where it's blocking the airway, contributing to snoring, and then later on in life, even sleep apnea. So that's one way that the tongue plays a role in sleep-related breathing issues. The other way is that the tongue serves as a scaffold for the maxillary arch. And so when you have the tongue in a high posture, thanks to Dr. Raphael for the animation as well as Dr. Nora Gadusi, you get a nice broad U-shaped arch because the tongue is kind of pushing the teeth right where they should be. But if you have low tongue posture, either due to tongue tie or due to mouth breathing, the tongue is dysfunctional as a scaffold. And so as the teeth come in, they get pushed by the cheeks and the lips. And you get a V-shaped arch where there's not enough room for the teeth. And then they present into your clinics with dental crowding. And we're fortunate that a lot of people here know how to treat this problem. It's unfortunate because I see way too many people coming in with orthodontists who are treating dental crowding by pulling teeth and retracting. And that's absolutely not what we want to do. Because when you retract, what you do is you get rid of the tongue space. Now the tongue has nowhere to be but down and in the airway. And so what we want to see is not this, but any kind of maxillary expansion. And so this is an example of one of the more traditional Hyrax maxillary expanders, not our preferred one because it does occupy some of the tongue space. The most ideal ones would be where you're expanding and allowing the tongue to help. But for all intents and purposes, any kind of expansion is moving in the right direction, and you're going to get a white flag for any time you're moving in this direction. And we saw in some of the talks yesterday that this is really possible without surgery very quickly and very effectively. But even if you do expand the patient, you're not done. You haven't cured the patient. You may have improved them by 70 or 80%. What's the next step? It's to get the tongue up on the palate. And so that's the goal. You want to get the tongue up to maintain optimal airway function. And the way you're going to do this is through myofunctional therapy. Can I have a show of hands for all the therapists in the room? And a big round of applause for all the work that you guys do. So myofunctional therapy is a set of exercises for the tongue, for the mouth, for the face. It also looks at, the more advanced providers look at the entire body, posture and physical therapy as well, with the goals of promoting exclusive nasal breathing, strengthening and toning the tongue and the orofacial complex, promoting ideal tongue posture, among many more. And there's now research that's done by our group from Stanford showing that myofunctional therapy works. It reduces the severity of sleep apnea by 50% in adults and 62% in children. It plays an important role in preventing relapse and effective in patients of all ages. But the problem is that myofunctional therapy can be limited when you have a tongue tie. If the tongue is physically tethered down, how are you going to get the tongue up? How are you going to get them to be exclusive nasal breathers? How are you going to get that mature swallow? And so that's what we're here to talk about today. In talking about tongue tie, there are a lot of experts who focus on the infants and toddlers. Dr. Richard Baxter edited a great book, Tongue Tie, which I highly recommend. Dr. Bobby Gahiri has a wonderful website with lots of resources for infants. And Dr. Larry Kotlow has been doing this work, especially for infants, for many years. I chose my focus of my practice to be on children and adults because this is where the research is lacking, and this is where we've dedicated our mission. Sometimes tongue tie is obvious, and sometimes it's not so obvious. Hopefully everyone in this room will acknowledge that this is a tongue tie, but you'd be surprised, you go to some meetings or you see some patients, and even these get missed. But for all intents and purposes, we're going to consider this to be obvious, and these to be not so obvious, but still tongue ties nonetheless. The standard way that most ENTs evaluate for tongue ties is the Kotlow free tongue measurement. This is designed not to look for sleep and breathing issues. It's primarily for swallowing issues, validated in patients age 18 months to 14 years. And what this does, it measures the length of the free tongue from the attachment of the frenulum to the tongue tip. And if you're less than 3 millimeters there, that's tongue tie. If you're 3 to 7, you're severe, 8 to 11, moderate. But if you're 12 to 16, you're mild. So let's take a look at this. Yes, this is severe tongue tie. Everyone would agree. How about this case? Is this case normal? And so this is the problem that we fall into. You refer the patient for frenectomy, they come back, doesn't meet the threshold, this is not a tongue tie. So we look at this girl, and we notice that, hey, she's not going to meet that structural definition. So what we did is with Dr. Audrey Yoon, we developed an alternate classification system, and this is based on the tongue range of motion ratio. What this does is it takes the tongue extension as a percentage of maximum vertical opening. So what you do is you have the patient patient lift their tongue up to the front two teeth, and then you take a measurement of the opening, and then you take the maximum mouth opening, and you get a ratio. So basically you're asking how far up can the tongue go compared to the maximum mouth opening, okay? And so if they're in the top, if they're able to lift it up more than 80% of the mouth opening, that's considered grade 1. That's top 10th percentile, that's ideal. That's where we try to get our patients after our procedures. Most patients in the population will fall in this grade 2 category, where they're between 50 and 80%. And then if you're less than 50%, then that falls into the grade 3 category. If you're less than 25%, that puts you as a grade 4. So what we're doing is we're moving away from talking about tongue tie, and we're talking more about tongue mobility. So you take a look at this case, and the maximum mouth opening is 58 millimeters. And when you get the tongue up, the vertical extension, you get 28 millimeters. You take a ratio, gives you 48.6%. That classifies you as a grade 3. And that's what we did with the Audrey Yoon study. But we're moving forward because I presented this, and people are like, but it's not about the tongue going up. It's about the back of the tongue going up. And that's because of the work that you guys are doing in educating us. And so when you get the back of the tongue up, the mouth opening is even more restricted, and it would be a grade 4. Okay? So we have to keep in mind that these are measurement tools that we're using for research and communication purposes, because ultimately what counts isn't whether it's a grade 3 or a grade 2 or a grade 4, but whether it's restricted or unrestricted. And this is what we're trying to do for our patients. We're trying to get them unrestricted. So what does the literature say about where we draw the line in the sand in terms of where we have to treat? We answered this question with another study in which we asked, could altered tongue mobility affect development of the maxillary arch? And we found that there was a direct line between those with grade 1-2 mobility and those with 3-4 mobility for narrowness of the maxillary arch, as well as an elongated soft palate. So we can summarize and say that there's now evidence that if you have a grade 3 and 4 tongue tie, very likely to have some kind of issue with the development of the jaws, TMJ, sleep, and breathing. And let's take a look at a couple examples of the grade 3s.
Guys, show your tongues. Who is the shorter frenulum?
Open your mouth all the way and lift up. Come a little closer and lift up. So it's less than 5% mobility to tip on either one. Lift up again, open up your other way, and lift up. There it is. Did you see that one?
Yeah.
Okay, and right here, lift up your tongue. I just can't do it. And look at Dad. All right. So now we're starting to appreciate that maybe it's not ADHD that these kids are having, that they're so squirmy. Maybe it's a real problem with their breathing. So grade 3 and 4 we understand, we have evidence for. What about this case? She's lifting up more than 50%. She's not a grade 3. So now we have to look for the compensations. And we're seeing that this is actually a case of a grade 3 compensating to grade 2. Why compensating? Because she's lifting up the floor of mouth. She has tension on the attached gingiva, giving it the Eiffel Tower appearance. She's engaging her whole entire neck and her facial complex just to lift her tongue. And then, so how do we control for that? All right, good. Okay. And then, so stick out your tongue for us. And lift up your tongue. Okay. Lift up the tongue to the front two teeth. Okay. So you can see that it looks like a grade 2 tongue mobility, but really she's bringing up her entire floor of the mouth. And if we hold her floor of mouth down, where it should be, and ask her to lift up, you can see she can't get it up. She just cannot get up her tongue, and you see the dimple right here that reflects the side of the frenulum attachment point. All right, so now we're able to see the tongue tie, and if you're able to see the tongue tie, then you can treat it. So here's a patient that we got into our study. So at the end of today's lecture, I'll talk about our retrospective study, and this is a patient that's going into our prospective study using sleep studies to determine the effects. So here we see that she started with apnea-hypopnea index in the 20s and 30s, that dropped into 9 to 13 range with a 65 to 80% improvement with just myofunctional therapy and tongue tie release. So here's another example, okay? And this is an example of a grade 3 compensating a grade 2 with floor of mouth elevation. If you were to take the traditional measurements that we did with Audrey Yoon, you'd get a grade 2, 70% mobility, and that's pretty good. But you have to notice that they're lifting up the floor of mouth here, and it's restricting the mobility of the back of the tongue. And so again, we're kind of pushing forward in terms of how we're talking about tongue ties. Yes, we have the grade 1, 2, 3, 4 category, but in our recent paper that we're about to publish and we're going to share with you later today, we're also talking about the compensation patterns. The grade 4s that compensate to 3, 2, or 1. The grade 3s that compensate to the 2s or 1s, and even the 2s that compensate to 1. And we're looking for these compensation patterns of the tension on the attached gingiva, the floor of mouth elevation, engagement of the muscular neck, not able to get their tongue up, as well as tongue-jaw dependency that Sandy may contribute in her lecture. So here we have a case, right? She's able to lift up her tongue. You don't have a tongue tie, but you look a little bit closer, you see how much she's straining in her face, in her neck, pulling up her floor of mouth. It's no surprise that these patients might present to you guys with TMJ, facial pain, neck and shoulder tension issues. And you can also see tongue ties on your CT scans. So, when you see these high arch palates, don't forget to look for, you see that dimple there? Don't forget to look underneath the tongue, because in fact you may have a restriction there. So that's how you evaluate the tongue tie, but it's not only enough to have a tongue tie to move forward. You also have to have an indication: mouth breathing, speech and swallow issues, tightness around the neck and shoulders, tenderness in the floor of mouth, and others. And so one of the more interesting reasons for treating this is the myofascial pain. So what happens when you can't lift up the tongue is that you compensate. Just imagine if you couldn't use your hands. What would you do? You would use your shoulders. You'd use your back. And then if you have a hand problem, it translates into a neck and shoulder and back issue. And that's what we see in our patients. When they can't lift up their tongue to speak, to swallow, to chew, what happens is they engage all these accessory muscles. These accessory muscles can get inflamed and irritated. Because, the tongue in these cases is physically tethered to the floor of mouth. So if they want to move the tongue and mobilize the tongue, they have to mobilize their necks. More than that, the tongue is a muscle that's covered by fascia. And every muscle in the body is connected together through this connective tissue matrix. And so imagine that you're covered in this fascia, all your muscles. And imagine you're in a coat that's just too tight for you. And it's kind of constraining you. It's going to pull you forward. And so just in order to speak or do anything, you're going to have to engage. And it's going to be hard to get out. And so here's an example where she's engaging her platysma. And this gets us to the deep front line of the fascia system. So there's actually a connection that goes from the tongue into the diaphragm, into the legs and the feet. It's all connected. Because we were doing these cases and time again, we get these incredible reactions. People are breathing better. Their posture's opening up. Their toes, they're feeling tingling and changes in their toes. So just let's listen to a couple of our patients.
I feel like I can breathe more in my diaphragm than I ever have, or at least in a really long time. I feel like I'm engaging my abs at a deeper level than I have been able to in a really long time as well. There's a flexibility in my spine, in my rib cage that I haven't felt in a really long time as well. I haven't taken in that much air easily in a really long time. And it's easy to do, whereas before this happened, I would have to it was strenuous to take in that much air. Now it's like I could sink into a chair much more easy, a lot easier than I have in a long time. So yeah, here I am.
So that's one, showing you the effect of this restricted fascia system, what can happen when you release them. You can finally take that breath of air. And let's listen to this guy. So we're here with Tyler for the second stage release for his grade 4 tongue tie. And he had some really interesting insights to share about the connection of the tongue to the fascia system.
So what I noticed was when we had started the procedure, my feet just sort of naturally had been, the right one was more or less vertical, but the left one had tipped out to the side. And when the first release happened, there was this kind of wave of relaxation that went through my body, and my left leg just very naturally on its own tipped up to be parallel. And that just was sort of the new natural.
Great. So just kind of reinforcing the connection of the tongue all the way down to the feet in the deep front line of the fascia system.
So moving on to how we doing these procedures to get these incredible results. So, there's two goals. One is to restore mobility, and the second is to optimize healing. And we'll go through this in detail. But a lot of times what we see is that we actually need to go a little bit deeper than what traditional procedures were allowed to do. And we actually go into the muscle tissue to perform a partial genioglossectomy. Now, the laser technique is excellent. It's much easier. It's very quick. Topical anesthesia only, almost no risk of bleeding. But really, it's only indicated for mucosal releases, because if you go into the muscle tissue, it's going to contract in. And so sometimes you have to go deeper. And so that's why we work with the scissors and sutures technique. It does require more skill, a little bit more time, but it allows you to go deeper into the fascia and the muscles. A lot of experts in the field. Here's Dr. Kotlow. He's using a CO2 laser. I think it's the Soleil laser. And you can see how he's releasing it here. This is an anterior tongue tie that he's releasing. And that's about it. Not really getting into the muscle fibers anything deeper, keeping his incision nice and small, because the smaller the incision, the smaller the scar line. Here's Dr. Richard Baxter doing a tongue tie in an infant. This is what you're using it for, you're going to get great results. Because we now have Dr. Chelsea Pinto in our office, and she's actually using the light scalpel to do our baby tongue ties. When it comes to children, I'm really not sure yet. And so what we're doing in our office is we're doing a study. Dr. Pinto is doing the children with the laser, I'm doing the scissors and sutures, and we're going to compare and see. But let's just take a look at what it looks like, the healing process looks like. Really the main difference is the open wound that you have to manage. Okay, so again, a very nice result using the laser technique for an anterior tongue tie. But sometimes you have to get in really deep, right? In order to free up the back of the tongue. And in these cases, you're going to need to do a frenuloplasty with a partial genioglossectomy. You're actually going into the genioglossus muscle. And so here's a 35-year-old female dentist, okay? And let's take a look at her case together.
Okay, hold on.
Okay, excellent. You feel this here?
Really no room.
Okay. Any feeling here?
So just do it. You already knocked up. I go ahead and I
You're doing
clamp.
great.
I pick it up. I clamp.
Good.
and I
Close and swallow.
Establish in small blood vessels.
Good. I go a little bit faster so you can catch more in memory. Cave up. Okay.
Let's check the volume a little bit here. I make the first cut. That's just the mucosa. Okay? And we stop there. So that would be your limit in the traditional
Close.
anterior release. Okay? So we got that in
Good.
mobility.
Just breathe it out.
A little deeper.
Good. Open.
So we're
Lift
not
up your
done.
tongue. Q-tip.
Here's what you would have
So
missed.
there's a restriction, okay?
You would have missed
You can
it.
see it right here. There's the restriction. Can I tighten this? I'm going to grab it like
Actually,
that.
fascia and muscle tissue.
Clamp.
Clamp it. Cut. And you can see
That's
all
the
fibers
release.
releasing now.
Close.
You see it? So it's releasing in the tongue. It's also going to go down and release in the chest.
Feel light here.
You feel it, huh? Okay.
And she's feeling it now.
That was the release, okay?
crazy.
Stop 30 seconds early, you would have missed this kind of result. Do you want the camera here still on?
Are we on?
We're just going to dissect a little more, but we can keep it going. We'll
Okay.
Keep it going. The procedure is we let
If you don't mind.
Okay. Yeah. Breathe, let her swallow. It's just, it can be personal and you may not want it, but this is yours, so you can.
Yeah, all I can see is your mouth anyway.
Okay, I'm gonna show all my patients. If I can do it, anybody can do it.
Lift up. Good. Okay, so much improved already.
Grade 1.
Much improved.
Oh my god.
Okay.
Oh my god, there.
Yeah.
Oh my gosh.
Experience to kind of
Okay.
see this.
Cave up.
Okay.
We have
Cave
her
up
do
for
the
me.
cave, hold up the back of the
Very
tongue.
good.
It's
You're
still
basically
a little
done.
bit restricted in there.
So I'll show you. So
Right there.
2 heads of the genioglossus muscle. A little fascia between it here. It's the limit. So you have maybe a little bit more to go.
See her response when I release this up. Just going layer by layer, identifying the restrictive tissue. Small cuts.
Good. See that? 2 heads of the genioglossus muscle. Look at
Nice and clean.
that. Get in there so she can see it herself very good with the camera. Suction up. See those 2 heads of the genioglossus muscle? That's usually your limit. Then you feel those and you see if they're restrictive or not. You're a little bit restricted there. I'm just telling you for later, okay?
Okay.
And then you can dissect. So we'll just take a break. Break. You're doing great. Tell us what you're experiencing.
It's just a sense of release. Just my chest. It's amazing. Like, I have some patients that would like cry, and I'm like, is it like real? I can't tell. But now I feel it. I know what they're feeling. It's amazing.
I'm lecturing tomorrow.
All right. So here's her case. Here's her immediate pre-op. So you may have even missed the tie in this case if you didn't know how to look for it. We have her do the suction cave, and you can see that it's restricted here. And so we go in, and now it's unrestricted. Easy mobility of the back of the tongue. Here's what she looks like post-op day 1. And here she is 2 months out. So San is going to talk about in the next segment the wound healing process, because as we follow these patients beyond 2 months, we see that this little scar that we have, even this loosens up, and you have improved mobility. By the 2-year mark, it's all one, and you don't even see that white line. So how do you know where to stop? Okay, so here we have a case where you may miss it if you don't see that he's lifting up the floor of mouth here. And this is another one of those compensating forms of tongue tie. And so the end point is natural,
And show me your cave again.
effortless, unrestricted.
And swallow for me. And how does the swallow feel?
Easily.
It's just natural.
So much easier, right?
Oh, it's like effortless.
Awesome. Thanks so much.
Insane.
And so these are the kind of outcomes we want to achieve. 1 week later, he's doing much better. But really, in order to do this, you have to do myofunctional therapy. You have to have the tongue up on the roof of the mouth, because when you have it, that's how you can see the posterior ties. And when you have your tongue up, it pulls away all these blood vessels and these nerves that are in your way. So that's why it's so important in order to have them adequately prepared. So we take a look at these 2 patients who are doing a Zoom video conference with me, and they're asking me if they're ready. He can hold it up. We say 45 seconds. He can hold it up. But as he's holding it up, he's engaging the floor of mouth here. He's lifting it up, right? So if we have to say who's ready for tongue tie surgery, we would say it's her and not him. He needs to do more therapy, not just more aggressively, but the right kind of therapy. And so 2 months later, right? Now he's giving me what I want. You can clearly see the restrictive tissue, and you can go in there, and he's pulling away all the blood vessels so that you don't get into that, you don't cause a mess. Here he was pre-op, immediately post-op, and 1 week later. And so now what I want to do is I want to share, for the first time, our results from our experience over the past 2 years. And as I do this, I'd like to invite all the therapists who participated. Will you guys please stand? Any therapist or any patient who's worked with us in the past 2 years, I'd like you to come up and join me as I go through the study. Yeah, sure. All the patients and therapists, because so what happened is we did in this project is we went through our first 420 cases that we've done over a 2 period. I want to honor you guys. Yeah, come on up. Yeah. And I'm sure we have more people.
This isn't the screening tool.
No, this is actually, so what we did is We went through and we kind of developed this protocol, right? And so it's really by the pushings of a lot of the therapists and the support of a lot of therapists that we have here that we even dared to go into this, because there was really no research at all, just a few case reports and case series that was supporting this kind of work. So for the first time here, we have literature, we have evidence with 340 cases showing that it's safe and effective to do tongue tie release for mouth breathing, snoring, dental clenching, and myofascial pain. And this work wouldn't have been possible without 45 therapists that actually work with us to carry this out among many, many among here. So can I have a round of applause for our therapists for all the incredible work. And our patients, yeah. So what we're seeing in our study is a 91% overall satisfaction rate. Okay, 2.9% were dissatisfied, 6% were neutral. We had an 87% improvement of quality of life. Okay, there was maybe one or two patients who did a little bit worse, and it's those patients that really taught us what to do and what not to do. And what we're finding is that the patients need to have room in their mouth for their tongue. And if they don't have enough room in the mouth for the tongue, then they need to have expanded, which still shows you that it's not only about the tongue tie release, and we need to collaborate together. And so the benefits, what are people saying? Overall, 96.5% of patients experienced improved tongue mobility, 91% reduction in clenching or grinding of the teeth, 90% of patients found it easier to do their exercises, 80% found it easier to swallow, improved sleep quality, improved nasal breathing. That was surprising to us at first. Neck and shoulder release in 78% of patients, and decrease in snoring in 73% of patients. We're really proud about this, but we also kind of put it out there. It's not a cure-all. It's not for everyone. And you really have to pick the right patient, and you have to have the right therapy as well. What are the risks of the procedure? There's pain. So 45% of patients report pain. 55% do not have any pain. There was 1.4% of patients who had pain for longer than 7 days. Bleeding, we don't use any cautery in this technique, so people can have bleeding for maybe the first day. 12.6% of patients, only 2% had prolonged bleeding. Numbness of the tongue tip, 4.9% reported that. Beyond 2 weeks was 2.6%. Minor salivary gland issues, 3.4 to 1%. There were 3.4% of patients who did better but needed to have a second stage release to go a little bit deeper. And there were 3.2% of patients who had the procedure, but they scarred down, they were a little bit worse. And so for the first time, what we have is level 3 evidence showing that this procedure, combined with myofunctional therapy, can result in a significant improvement in patient comorbidities. So moving from there, we're now looking more closely at lip ties, when to treat them. So lip ties can cause issues with brushing, can contribute to a diastema, can retard maxillary growth, can contribute to oral incompetence, leaving the lips apart, and interfere with myofunctional therapy. And we're now trying to study this more in detail to try to figure out which kinds of tongue ties need to be released. Kotlow classifies them 1 through 4 based on the insertion of the lip tie. So what you see is you have class 1, that's mucosal, class 2, that's gingival, class 3, that's papillary into the interdental papillae, and then class 4, that penetrates all the way into the palatine process. This is how you grade lip ties. But the research shows that most patients, in fact, most babies are grade 2s, right? So what's normal and what's not, you can't really do it based on where it attaches. Rather, the question is you have to assess for the mobility. So you lift up the tongue and you're looking for the tension just like you would in a tongue tie. You run your finger across there and you ask yourself, is this restricting the tongue mobility? And in this case, you see you're pulling up the lip, but it's blanching on both ends, and you can say, yes, this is a restrictive lip tie. There's different ways of approaching this. My preference is the V to Y lip lengthening. What we do is we don't remove any tissue from the patient. We actually use this tissue to lengthen the upper lip. So a patient comes with oral incompetence, difficulty getting their lips together without straining their mentalis. And we're not only releasing the lip so it comes down, we're actually lengthening it, making it much easier for them to get their lip seal. This is how Dr. Kotlow will do it with the lip.
You all right? Okay, close your eye. What'd you think of that? Oh, stay right here. Is that okay? What did it feel like?
And he's doing well. So now moving on to buccal tie releases, and buccal ties can actually contribute to recession, as we're seeing on the premolar here. So there's different ways of approaching buccal tie releases. You can go in with a laser. You can go in with just a scissors and cut it. What we're working on doing is actually a submucosal approach. So what we do is we go in from the midline, the existing lip, and we can tunnel through to release it, either with a Q-tip or with a dissecting hemostat. You can actually release the buccal ties submucosally and get it all along. And so, we've done several cases, and I thank Sanda for helping us to kind of think about this. And as we're pushing the boundaries and trying these techniques, we're getting really incredible results. Here's a patient who reported, not only is my tongue resting on the roof of my mouth, the amazing release of my labial buccal ties. Incredibly phenomenal. I've been breathing through my nose day and night, which feels incredibly profound. When the buccal ties were released, I felt a release in my suboccipital muscles. Lip ties are really important, not just for breastfeeding, but for breathing. Posture much more effortless, breathing coming from my diaphragm, spinal twist easier. I'm waking much more refreshed. My lips firmly pressed together. I'm excited to see how this goes with other areas of my life. Social interactions feel easier. Speaking feels easier. And so this is level 5 evidence saying, hey, we're on the right track. The other area that's really interesting for me that I'm kind of exploring now is the mandibular labial frenum, so the lower lip. And so this is actually based on work by Roccabato that Valerie Sinkus actually kind of brought up to me. And what we're seeing here is that some patients can have a very tight restriction between the lower lip and the mandible. And so we see these very commonly in patients who are failing to progress in their dental orthopedic remodeling. So you're putting in an ALF, a Crozat, all this kind of stuff, but their swallow pattern is retarding the lower lip, kind of pushing it back, pushing it back. And so what this paper says is, hey, you can release this, and maybe your patients will do better. So we're trying it. And so here's one of our patients. You can take a look at her swallow. She's engaging all of her lips and orofacial complex, kind of pushing in. And so with each swallow, you're retarding the growth. And so in this case, immediately after, already much less tension, mobility to her lips. And finally, day 4, she's giving her swallows with almost no engagement of her lips and orofacial complex. Other interesting things. Here's another case that I did. This is a tongue tie and a mandibular frenum release. He already had a prior tongue tie and went back to revise it. How does releasing the tongue tie help? Well, if you can't get your mandible forward with the appliance, sometimes with each swallow, the tongue is holding it back, right? And the lips are holding it back. And so you're trying to put him in the orthotropics or the ALF or whatever you're doing, and it's not working out. So let's hear about this patient 2 weeks ago.
Why don't you tell us what you've noticed different about your bite since having the procedure done?
It now goes straight and it's on overbite.
Show me. That's where it naturally sits?
Yeah.
Where did it sit before? And now that feels awkward for you and that feels more comfortable, right?
Yep.
Okay, and that's different after the procedure?
Yes.
Okay, great. Lift up your tongue for me. Trace it back and forth. Trace it back and forth like we said. Okay, great. And we said it's going to loosen up and open up more with time. Fantastic. Put your lips together and give me a swallow. Great.
All right. And so, we're really onto something, but we have to remember that it's not just about surgery. It's also about the function. And so we're really fortunate. I'm really fortunate to be able to combine the surgery with the therapy, with Sanda here by my side, discussing these cases to bring a functional approach to the frenuloplasty. And it's not just the two of us, it's actually an entire team. And so I'd like to have my team stand up if you guys don't mind. And I want to, really honor Layli Noruz, our managing director. Layli, will you raise her hand? Yeah. She's really... She's really the glue that brought Sanda and I together and that brings our entire team together, a real driving force. I want to acknowledge Chad, our media director, as well, for helping us with the videos and all the work that they're doing. And, we give courses, and the courses that we do, the funds from them really help support the research that we're doing. We now have 2 full-time research associate assistants and 3 part-time research assistants. And we also are privileged now to get funding from philanthropists and donors to help our disadvantaged children and to really honor the work that they're doing, taking a functional approach to sleep and breathing issues that can potentially be much more effective and long-lasting. So with that, I really want to thank you, all my teachers, collaborators, and colleagues for inviting me to speak here, for your continuous support, and thank you so much.